A very good afternoon to all of you. Today I would be sharing my knowledge on statins for all diabetic patients. My objectives would be diabetes and CVD, role of statin and CVD prevention, adverse effects of statins, recent guidelines, relevance to Indians, and take-home message. Now, we are all well aware diabetes is a very strong cardiovascular risk factor, and almost 2/3 of patients, diabetic patients, die of cardiovascular mortality. And cardiovascular disease is 4 times more common in diabetics as compared to non-diabetics. Even before the diagnosis of diabetes, impaired glucose tolerance is a very strong cardiovascular risk factor. Most of the patients have evidence of CVD at the time of diagnosis of diabetes, and CVD in diabetic patients is severe, silent, got a poor prognosis and very high mortality. 70% of type 2 diabetic patients have premature death because of cardiovascular disease, accounting for almost 30% of deaths. Now, this study by Steve Hefner, and it was shown that diabetes can be taken as a CAD risk equivalent. Now, LDL levels may be normal or maybe little high in diabetic patients, but small dense LDL particles are very high, which are more atherogenic. Now, this is what is small dense LDL particle, which are more atherogenic. So this is the main culprit in type 2 diabetic patients. And there is a linear relationship between LDL and cardiovascular events and mortality. For every 30% change, for every 30 milligram percent change in LDL, there is increase in CHD by almost 30%. Statins have a proven record in prevention of cardiovascular events. Now, meta-analysis, 14 RCTs, 90,000 patients, 1 millimole per liter reduction in LDL was associated with 23% reduction in cardiovascular death, 24% reduction in CABG, and 70% reduction in stroke. Statin use in diabetics, again there is a very significant improvement or reduction, in fact, in cardiovascular events as in non-diabetic patients. Now, again a very important trial, CTT collaborators, was published in Lancet, and here also we can see there is a favor towards statin as far as cardiovascular events are concerned. Now, major statin trials: primary prevention, WASCOPS, we have ESCOT LLA, we have CARDS, and then Jupiter, number of other studies, secondary prevention, 4S care, lipid. All these trials have shown that when patient is given statins, there is a significant reduction in cardiovascular events as well as mortality. In this trial, CARDS trial, there were almost 3,000 patients, age 40 to 75 years, all type 2 diabetes, and they were having either one of the two, either hypertension, retinopathy, albuminuria, and median duration was almost 4 years. Atorvastatin was given, and it was found that there was reduction in primary endpoint by almost 37%, reduction in any cardiovascular endpoint by 32%, and all-cause mortality by 27%. And statins are not just lipid-lowering agents. It is much beyond that, and there are a number of pleiotropic effects of statins. I think we are all well aware of that. But at the same time, we should not take them as a placebo. They do have adverse effects. And these adverse effects are: one, a new onset of diabetes. It has been mentioned in many trials, but it depends on the dose. Higher the dose, longer the duration of statin treatment, more are the chances of new onset diabetes. One, it is more common in women and in older patients. But at the same time, cardiovascular benefits of statin outweigh the risk of new onset diabetes. So this is not really an adverse event, and we don't stop statins even if there is development of type 2 diabetes. Then other adverse effects are myalgia, which is quite common, but it also subsides with time, and maybe where these patients do have vitamin B12 and D deficiency. So if we replace that, this problem is also sorted out. Myositis is only in 0.1% of cases, and rhabdomyolysis is very, very rare. Abnormal LFTs again 1 to 2% in first to 3 months, and there is a spontaneous resolution. So there is no need. Only rarely we have to stop statins. And rarely when LDL falls, so this is very important. That is why LDL targets have to be taken into consideration. If LDL falls below 50, it has been seen that there is impaired cognitive function and maybe hemorrhagic stroke. So this is one point which is to be taken into consideration. Let's come to major guidelines. Now ACCIAHA 2013 guidelines, the most controversial guidelines till date. As per these guidelines, statin should be given to these 4 categories of people, either in moderate intensity or high intensity. People who have clinical ASCVD, atherosclerotic cardiovascular disease, age more than 21 years, they all should be given statin high intensity. When LDL cholesterol is more than 190 or more, between the age of 40 to 75, all diabetics should be given, even non-diabetics should be given statins. Then all diabetics between 40 to 75, even if LDL is less than 190 but more than 70, they should be given moderate to high intensity statins. And when estimated CVD risk is more than 7.5%. So these are the 4 categories. But these guidelines, this is the risk calculator, pooled cohort equation, on which we have to calculate the cardiovascular risk. Now, there was a lot of criticism about these guidelines, and it was told that they are statin biased and Asian subjects were not taken in the randomized controlled trials. So Asian patients, especially Indians, we have a different atherogenic lipid profile. It is not LDL, it is mainly high triglycerides and low HDL. Then American Association for Clinical Endocrinologists also declined these guidelines, and they said, we respect the intent but not the content. Now recently in November-December 2014, there is a consensus statement on management of diabetes, on dyslipidemia in Indian subjects. This has been printed in Indian Heart Journal, December or November issue 2014. And these guidelines, there is LDL target also. Because ACCIAHA there was no LDL target. Only you start giving statin and continue the same dose forever. As per these guidelines, the Indian consensus, if patient is having moderate to high risk, that is more than 20%, 10-year more than 20% cardiovascular risk, the target is less than 70. But when risk is between 10 to 20%, LDL target is 100. Now, even in January 2015, ADA has come out with guidelines for diabetic patients. There is some change as compared to previous 2014 guidelines. And these guidelines are in association with ACC. And ADA says that statin initiation is driven primarily by cardiovascular risk and not LDL levels. Because if we go back to 2014, it was based on both cardiovascular risk as well as LDL target. But now it is mainly based on cardiovascular risk. So patients who have overt CVD, definitely it has to be given, we all know. Without overt CVD, all diabetics between 40 to 70 years of age, and if there is additional cardiovascular risk factor, they should be given high intensity statins as per ADA 2015. And if they do not have any additional cardiovascular, then moderate intensity statin. Patients who are less than 40 years of age and they have additional cardiovascular risk factor, give moderate intensity, and if there are no additional risk factor, no statin. So diabetic patients less than 40 years, no cardiovascular risk, no statin. Other is patients who are more than 75 years of age. If there are additional cardiovascular risk factors, give high intensity, and if there are no additional, then you give moderate intensity statins. So if you analyze all these guidelines, ACC, AHA, Indian consensus and ADA 2015, we can say diabetics who are more than 40 years, if they have additional risk factor, you start with high intensity statin. If they do not have high cardiovascular risk factor, give moderate intensity statin. Now, diabetics who are less than 40 years of age and there is no cardiovascular risk, don't give statin. So, statin for all diabetics doesn't hold true here. Less than 40 years, no risk factors, no statin. Then diabetics more than 75 years, moderate intensity statin can be given, unless until they have a very high cardiovascular risk. Now coming to LDL targets, if we analyze all these guidelines, they are very important. If patient is having moderate cardiovascular risk, the target is less than 100, and patients who have high cardiovascular risk, LDL target should be less than 70. And why this LDL target? Because to know the adherence to treatment, whether patient is taking treatment or not, it is very important. We can always counsel the patient. If we are not achieving the targets, then response to statin, and once LDL goal achieved, suppose we start a patient on high intensity, LDL goal is achieved, we should reduce the dose to a moderate intensity, not that we continue giving high intensity forever. And relevance to Indian, these guidelines, if we combine all these and see Asian patients, lot of studies are there, they respond very well to statins. Even in your clinical practice, you must have seen many patients, they respond well to 10 to 20 milligram of atorvastatin or maybe 10 milligram of rosuvastatin. IRIS study showed in Japanese that 10 to 20 milligram of atorvastatin or rosuva of 10 milligram per day was associated with almost 40 to 50% reduction in LDL. It is almost same as high intensity statin as per ACC. The reason may be that patients have lower BMI and there is a slower statin metabolism. Now there is another trial, mega trial, where again pravastatin was given in a dose of 10 to 20 milligram per day, and there was 33% reduction in coronary heart disease. And high dose statins. So if we can achieve the result, LDL goals, then why not we give low or moderate dose? And high dose, there are more adverse events and increased cost, especially in Indian patients. The cost is also very high. So the most prudent approach, according to me, would be, when we see all these guidelines, in Indians especially, we should start with a low dose and slowly up titrate, maybe except in high risk category. Patient who is coming to you with diabetes, with acute coronary event, acute MI, obviously, there we have to start with high intensity. But in moderate risk, like we should start with low to moderate intensity statins. And in Indians, there is more of atherogenic dyslipidemia, means high TG levels, low HDL and increase in small delta LDL. LDL goal can be achieved with low dose statins in Indians. And once we achieve LDL target, it is again important to achieve LDL target, because still the risk remains, and then we can target non-HDL and followed by HDL goal. ACC 2014 annual conference, and it was discussed benefits and risk of statins, and it was mentioned that benefits, they likely to outweigh the risk in high risk category. So take home message, friends, is that diabetes is a coronary artery risk equivalent. There is a moderate to high risk category. We have to have aggressive approach, no doubt. Patients who are on moderate to high risk category, we have to be aggressive. Statins have a proven efficacy. Benefits outweigh the potential risk. Adverse effects are, I have already told you, new onset diabetes, abnormal LFT and myalgia. Indian patients, they have high triglycerides, low HDL, high small dense LDL. Asians respond more strongly to statins. Even low to moderate dose is sufficient to bring down LDL levels. High dose statin is a difficult option in Asian patients. And role is controversial in patients who are having low cardiovascular risk. Let's say less than 40 years of age, why to give statin in such a patient? So, best strategy would be start with low dose, gradually up titrate, especially in moderate category, but when patient has a high risk cardiovascular modality, high cardiovascular risk, then definitely we should straight away start with high intensity statins. Patient-centered approach is the most important. Physician should be cautious and vigilant regarding statin use. and we should carefully balance benefit and the risk. Lifestyle modification remains the cornerstone. I mean, it's not that we start statin and we forget about lifestyle. It has to be endorsed on each and every visit. And as far as conflict of interest is concerned, nothing to declare. And I convey my thanks to all of you for your patient listening.